Welcome to ReviseMED. I am Dr. Vijan. Today we will be dealing with a new topic, that is catastrophic APS, which is a small topic. I hope all of you will enjoy this topic. So let's get into the topic. Catastrophic APS is also known as Asherson syndrome, which is a most severe clinical manifestation of antiphospholipid syndrome. CAPS is defined by the three cardinal features, that is the rapid onset of thrombotic events involving 3 or more organs, systems or tissues typically occurs within 1 week. There should have a histopathology confirmation of small vessel occlusion in at least one organ or tissue, and laboratory confirmation of antiphospholipid antibodies, that is lupus anticoagulant, anticardiolipin, anti-beta-2 glycoprotein on 2 occasions at least 12 weeks apart. And even a single positivity in APS antibodies will be considered if there is an appropriate clinical context. If all these features are present, then we will tell that the patient is having CAPS. Otherwise, if they are not satisfying the all 3 criteria, then we will call them as probable CAPS. So coming to the epidemiology, the incidence of CAPS occurs in less than 1% of all APS patients. When you come to the demographics, that is antiphospholipid syndrome is predominantly affect young to middle-aged women, while CAPS occurs in both males and females and all age groups with a slight female. Coming to the triggers, approximately 50 to 60% of CAPS episodes are precipitated by a clear trigger, most commonly infections that can be viral or bacterial, surgical procedures, malignancy, and abrupt withdrawal of anticoagulant patients. Suppose a APS patient is taking anticoagulation, that is azithromycin or warfarin, and he is stopping the drug or he is not compliant to that drug, then these patients are more prone for having a CAPS event. We will get into the overall pathological outline regarding the APS. These APS antibodies, that antiphospholipid antibodies, will activate platelet, monocyte and endothelium. That's the key concept. APL antibody directly bind to platelet and cause aggregation and release of microparticles that accelerate the formation of blood clots. Similarly, it binds to monocyte and release tissue factors, which is a key initiator of coagulation cascade. APL antibody also binds to the blood vessels and it increases the expression of adhesion molecules and as well as the release of tissue factor, again promoting more thrombosis. So we all know pathogenesis of APS is based on a 2-hit hypothesis. Here in CAPS also similar, it is a 2-hit hypothesis. So the primary hit is considered as those patients who are having a high titer of antiphospholipid antibodies. So some genetic factors also will be playing the role of primary hit. The second hit is considered as the trigger, that can be infection, surgery or anticoagulant withdrawal. These will initiate a systemic inflammatory response. Once these events are occurred, it will lead to a widespread cellular activation, that is APL will bind to platelet, monocyte and endothelial cells and initiating a prothrombotic activation. So once the cellular activation occurs, it will be amplified by the complement system. This complement system amplification is one of the key feature in CAPS, which is not seen in case of APS. Once the complement system or complement cascade is massively activated, it will release C5a and MAC complexes, which will again drive severe inflammation and lead to endothelial damage. C5 is a chemoattractant. It will attract neutrophil to the site of inflammation. Neutrophil will have neutrophil extracellular traps, which provides a scaffold for clots as well as increasing the endothelial damage. So these ultimate damages will again release DAMs, that is DAMs associated patterns, which again fuel the inflammation. So a vicious cycle is produced. So ultimately from the CAPS we are going to get 2 storms. There is a thrombotic storm, there is a cytokine surge storm. So both storms are leading to massive inflammation as well as thrombosis. That's the one of the core concepts, because in the treatment we are going to target the thrombotic storm as well as the cytokine storm. Then only we are going to control this disease. Thrombotic storm as well as the cytokine storm will lead to multi-organ ischemia and failure, that is widespread microclots blocks the blood flow to the vital organs, resulting in ischemia, infarction, and systemic organ failure. So let's revise the pathogenesis. As we already told that CAPS is a two-hit process. The first hit is considered as the predisposition for CAPS or APS, that is the presence of antiphospholipid antibodies in these patients as well as some genetic factors. Second hit is the triggers, that is infection, surgery, malignancy, as well as the abrupt withdrawal of anticoagulants. These ultimately lead to two storms, that is cytokine storms as well as thrombotic storm. So these are the common triggers which are precipitating CAPS. That is, one, infection is the most frequent trigger, then surgical procedures, anticoagulation and non-compliance, malignancy, and trauma and obstetric complications. The hallmark of CAPS is considered as, that is, rapid onset, that symptoms develop in less than 1 week, and multi-organ involvement, that is, it affects at least 3 or more organs, that is kidney, lung, brain, and heart, and microthrombosis, usually confirmed by histopathology of small vessel vascular occlusion and presence of antiphospholipid antibodies. So these are the hallmarks of this crisis. So what are the clinical features you can expect in case of CAPS? CAPS is essentially a thrombotic storm. So most commonly organs are kidney, which can cause a acute renal failure, proteinuria, and hypertension. In lungs, it causes acute respiratory distress syndrome, pulmonary embolism. Central nervous system can present as encephalopathy, seizures, strokes, and heart, myocardial infarction, and cardiac failure. Adrenal gland involvement is one of the characteristic features in case of CAPS. It will cause Waterhouse-Friderichsen syndromes, leading to adrenal insufficiency. And skin manifestations such as livido reticularis, livido racemosa, digital gangrene, and purpura can be seen. So when to suspect CAPS? There should have a temporal association, that is, the onset of symptoms in 3 or more organs should occur within a week. And this mostly occurs in a case of non-APS patient. The patient who have established APS, who is developing a multi-system deterioration within a week, then you should suspect CAPS. Then the presence of recent triggers such as a recent infection, surgery, and anticoagulant withdrawal in case of APS patients. And those who are having a refractory cases, such as the patient is having a presumed sepsis or DIC or a thrombotic microangiopathy which is not responding to conventional therapy in an ICU, we should have a differential of CAPS in our list. So how you can proceed or investigate CAPS? So when you consider the laboratory investigations, first you have to do is a coagulation panel. On that you will have a prolonged APTT, which is due to LAC, that is lupus anticoagulant, and the D-dimers will be usually elevated in case of CAPS, or that is suggestive of ongoing thrombosis. Antiphospholipid profile you should do to detect whether they are having APS antibody positivity, and complement levels. Usually complement levels will be low in case of CAPS because complement activation or complement cascade is the central amplifier which is occurring in case of CAPS. And the inflammatory markers such as CRP and ferritin will be elevated. So if an SLE patient is having CAPS presentation, the CRP will be elevated. Usually SLE will have normal CRP. Coming to imaging, imaging is usually done to demonstrate the thrombosis or an end organ damage. So if you are suspecting a macro thrombosis, you can do Doppler ultrasound, and CT and MRI can be done to assess the organ involvements, especially if you are suspecting a renal infarction or a cerebral infarction or a pulmonary embolism. You can do CT or MRI. An echocardiogram can be used to assess any intracardiac thrombi or a myocardial dysfunction. Coming to histopathology, biopsy of an affected organ, especially most easily assessed organs are skin or kidney, typically reveals extensive microvascular thrombosis with minimal inflammation. So coming to the pillars of management, the treatment of CAPS is aggressive and multimodal, aimed at controlling both clotting as well as controlling the inflammatory response. The therapy should be initiated immediately upon suspicion, and the pillars for this treatment include anticoagulation, because we have to stop the ongoing clot formation, that is thrombotic storm should be stopped. And the treatment of choice for this management or anticoagulation is the unfractionated heparin. And corticosteroid, that is high dose corticosteroids to suppress the severe systemic inflammation, that is the cytokine storm we have to tackle. Then you can use plasma exchange to remove the harmful antibodies and inflammatory mediators from the blood, or IVIG to help or modulate the overactive immune system. So this is the triple therapy. All CAPS patients should get triple therapy, that is anticoagulation with high dose corticosteroids, pulse corticosteroids along with plasma exchange or IVIG. There is no randomized controlled trial in case of CAPS because disease is very rare. So from the observational data released by the International CAPS Registry, what they are suggesting is all patients should get an immediate anticoagulation, that is intravenous unfractionated heparin is preferred. While treating with heparin, you should maintain this patient by monitoring APTT, that is 1.5 to 2.5 of the control value. By giving anticoagulation, we can hold the process of thrombosis. And high dose steroids, usually what we are using is the medial prednisolone 1 gram IV daily for 3 days followed by tapering. This usage of steroids attenuates the cytokine release as well as dampens the autoantibody mediated injury. Coming to plasma exchange with or without usage of IVIG, plasma exchange daily for 3 to 5 sessions removes the circulating antiphospholipid as well as the inflammatory mediators, and use a IVIG 0.4 gram per kg per day for 5 days provides a immunomodulation. The rationale for using triple therapy is based on the CAPS registry data, which demonstrate that if you are using triple therapy at the earliest, the mortality has reduced from the 50% to 30% in patients if you are using anticoagulation and steroid alone. So it is better to use triple therapy at the earliest to tackle this disease. So if the patient is refractory to the triple therapy, you can use rituximab, and it acts by depleting the B cells. It targets the CD20 that we all know. And you can also use eculizumab, that is complement 5 inhibitor in patients who are having refractory CAPS. And for the regarding the long-term management, once stabilized, the patient requires lifelong anticoagulations, that is traditionally with warfarin targeting the INR 2.5 to 3.5. And direct oral anticoagulants are generally avoided in high-risk APS, especially triple positive APS as well as CAPS patients based on the TRAPS trials, which demonstrated a higher arterial events. So coming to the prognosis, the mortality is very high. Historically, it is 50%, but with early recognition as well as the aggressive triple therapy, the survival has been improved to 70%. And when you are talking about the relapse rate, up to 30% of survivors may experience recurrent CAPS. This highlights the need of long-term follow-up as well as maintenance anticoagulation in these patients. So let's summarize the difference between classic APS as well as CAPS. When you are talking about the onset of CAPS, it is an abrupt event. It's more like a medical emergency. It occurs less than 1 week and affects more than 3 organs or tissues. The thrombosis in case of CAPS is predominantly microvascular, while in case of classic APS it is more likely a large vessel involvement. Classic APS can also involve microvascular involvement, can be also seen in case of APS nephropathy, but it is predominantly a large vessel involvement, and the inflammation is mild to moderate in case of classic APS, while in CAPS it is a severe systemic inflammatory response, and complement activation is the central or core driver in case of CAPS, and the mortality is very much high. It is up to 50% in case of CAPS. With this, we are going to end this session on CAPS. I hope all of you have enjoyed this session.